Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam, and I have been a cardiologist for more than 30 years at the Texas Medical Center. And today we are going to learn something about triage, diagnosis, and management of acute myocardial infarction patients in the immediate phase and in the long term. So let us begin. Acute coronary syndrome is a situation where somebody can present with chest pain and have normal cardiovascular evaluation all the way to someone with a STEMI and cardiogenic shock or cardiac arrest. In this presentation, we are going to focus on STEMI patients. The objectives of this presentation include an overview of acute coronary syndrome, pathophysiology of acute coronary syndrome, prompt recognition of STEMI, triage and management, fibrinolytics versus urgent PCI versus urgent coronary artery bypass surgery, early recognition and treatment of STEMI complications, medical management, short-term and long-term management with secondary prevention of further cardiovascular events. Whenever someone presents with an acute chest pain, we call that as acute coronary syndrome. So let us focus on STEMI patients for the rest of this presentation. Before we go any further, we need to understand the coronary anatomy and correlate that with the electrocardiographic findings on the patient's overall condition so that we are in a much better position as to how we can treat these patients in an acute situation and on a long-term basis. Here is the left main coronary artery, which arises from the left coronary cusp. It divides into the left anterior descending branch, which gives rise to the septal branches and the diagonal branch. The left anterior descending artery supplies the septum, the anterior wall, and some of the left ventricular apex. The circumflex branch comes from the left main coronary artery, and it wraps around the left atrioventricular groove and gives rise to the marginal branches which supply the lateral wall of the left ventricle and posterior wall of the left ventricle. If there is an occlusion of the left anterior descending artery, we are going to see an anteroseptal and apical myocardial infarction, whereas occlusion of a circumflex branch can result in lateral and posterior myocardial infarction. The right coronary artery arises from the right coronary cusp or the anterior cusp, and it gives rise to the sinus node branch and the acute marginal branches which supply the right ventricle. The right coronary wraps between the right atrium and the right ventricle to the back of the heart, where it gives rise to the posterior descending branch which supplies the inferior wall and to some degree the septum of the left ventricle. Thus, an occlusion of the right coronary artery can result in an inferior and infraseptal myocardial infarction. It can also result in right ventricular infarction if the proximal segment of the right coronary artery is involved in an occlusion. The coronary artery syndrome is a spectrum which ranges over 5 to 6 decades. Initially, with hypertension or hyperlipidemia, they may have no symptoms whatsoever except for the risk factors. To that, if you add smoking and diabetes, the risk tremendously goes up. Then there is early development of atherosclerosis, which can then lead to minor symptoms of ischemia with moderate exertion, which can bring patients to the medical attention, and then it progresses on to coronary thrombosis, acute myocardial infarction, arrhythmias, remodeling, ventricular dilatation, congestive heart failure, and finally end-stage heart disease. Let's just focus on STEMI for right now. Here is a atherosclerotic plaque evolution, which may take 3 to 5 decades to develop. First starts off with intimal thickening and fatty streaks that leads to progressive plaque buildup with cholesterol, platelets, calcium, and when it gets to a range of 50 to 75%, then patients begin to have symptoms. In the later stages, when the stenosis becomes more critical, there may be a rupture of a plaque with the formation of a blood clot that can totally occlude the coronary artery that leads to STEMI, or ST segment elevation myocardial infarction. Here is a cross section of the artery showing the same thing. First we have the buildup of a plaque in an arterial wall that leads to a cap that can rupture, and that can lead to formation of a blood clot inside, and if there is still a lumen present, then it results in a NSTEMI. But if there is total occlusion of the coronary artery, it results in a STEMI presentation. If there is ST segment elevation, and if we have facilities for acute coronary intervention, they go for primary coronary intervention. If there is no facility available, then you think about fibrinolytic therapy. If this is a non-STEMI, you look at risk factor assessment and the clinical presentation, and the subsequent treatment is going to base on these findings. When someone walks into the emergency room holding their heart in their hand, that may be a classic sign of an impending acute myocardial infarction. Again, if there are classic changes of STEMI, the patient will be categorized to STEMI management. If there are no EKG changes or minor EKG changes, then based on the cardiac enzymes, they are classified as NSTEMI or just simply unstable angina pectoris. Let's talk about initial management of a patient with STEMI. Let's say the ambulance has already called about this patient whose electrocardiogram has been transmitted to the emergency room, and you or the doctor, the fellow, the resident, or the student in the emergency room expecting to see this patient. Here are some of the key things that we need to keep in mind. When a patient comes into the emergency room, we are going to treat them with aspirin, nitroglycerin, beta blockers, heparin or low molecular weight heparin, ACE inhibitors, statins, and antiplatelet agent. Let's start. The patient is in the emergency room, and you have an electrocardiogram which looks like STEMI. What do we do next? Of course, you get an electrocardiogram and confirm your diagnosis of STEMI. These patients are immediately started with aspirin 160 to 325 milligrams, preferably chewable. If they are still having persistent pain, they can be treated with sublingual nitroglycerin or nitroglycerin intravenously through an infusion. If the pain is not relieved with nitroglycerin, they can be treated with morphine. If their blood pressure and vital signs are stable, they can be treated with beta blockers initially. However, the beta blockers need to be avoided if there is any evidence of hypotension or bradycardia. Again, these patients can be treated with ACE inhibitors if their blood pressure is stable. Antiplatelet agents in some instances are started in the emergency room, but certain other places they may wait till the PCI is completed. So in the event the patient needs to go for coronary artery bypass surgery, you don't want to load them with antiplatelet agent. Once you have established what is going on with the patient in the emergency room, then we activate the cardiac catheterization laboratory. Here is an example of an acute high anterior and anterolateral myocardial infarction. This is an extensive infarction involving the anterior wall, the septum, and to a certain degree the lateral wall. When you see something like this, you always worry about not only myocardial infarction and chest pain, but also about cardiogenic shock and arrhythmias because of the extensive nature of the myocardial infarction. Let's go back here, and this may be related to an acute occlusion of a very proximal left anterior descending artery and hence needs very aggressive treatment. Here's an example of an anterolateral myocardial infarction along with right bundle branch block, which is often seen with the involvement of the septum. This patient needs acute aggressive treatment to reduce the extent of myocardial damage and preserve the left ventricular function. Now we are looking at ST elevation in lead 2, 3 and ABF along with some R wave and ST depression in the anterior leads, which not only suggests an acute inferior myocardial infarction and possibly posterior infarction, and this usually results from occlusion of the right coronary artery. Is also some involvement of the lateral wall, and this could also be from a large distal circumflex which gives rise to the PDA. There are some situations where it may be difficult to diagnose acute myocardial infarction with the classic ST segment elevation of more than 1 millimeter in 2 or more leads, and that can happen in patients with the left ventricular hypertrophy who already may have ST elevation in the anterior leads as part of left ventricular hypertrophy, or we may be dealing with a patient with the left bundle branch block where the diagnosis of acute myocardial infarction is a little complicated. Similarly, a pace rhythms may pose a challenge in diagnosing an acute Stemi. Here's an example of a left bundle branch block where we may have trouble diagnosing an acute myocardial infarction. As you can see, even in normal situations, there is ST elevation and slightly peaked T waves. However, the clinical presentation needs to be taken into consideration when we are looking at these types of patients. But if you have a patient with a significant symptom along with left bundle branch block, when you're in doubt, proceed to coronary angiography and then decide what needs to be done. Again, we keep coming back to this protocol of medical regimen time and again because these are the things that need to be routinely done in patients before the diagnosis, after the diagnosis, in the intensive care unit, and in short-term and long-term management. So that's why I think these patients need to be treated with aspirin, as we talked. And when they are in the emergency room, we get the electrocardiogram and get some oxygen. Pulse oximeter is placed to measure oxygen saturation and peripheral circulation. Nitroglycerin and morphine for chest pain, beta blockers if the blood pressure supports, low molecular weight heparin. ACE inhibitors can be started immediately after the intervention, and in the immediate and short and long term they need antiplatelet agent, especially P2Y2 inhibitors. Then we'll talk about high intensity statin. As soon as you diagnose a STEMI, the next step is, after having taken care of all these elements, activate the CATH lab. The goal is to accomplish percutaneous coronary intervention in less than 90 minutes. What more do you want to know in the history? You may be thinking, what do you mean history? We already got an electrocardiogram. A picture is worth 1,000 words. Why do you need history? Let's get to the CATH lab. Hold it. Yes, history is very important because as soon as the patient comes to the emergency room, we have taken care of all the things in less than perhaps 10 minutes. But it will be at least 30 minutes before the CATH lab is ready to begin the procedure. And in the meantime, we can take plenty of history which will help us to better manage these patients besides coronary intervention as such. We need to know if this patient is having shortness of breath. That may be an indication of pre-existing lung condition, or it could be a new symptom which can reflect congestion, which may reflect low cardiac output or reduced left ventricular function. Dizziness, it's another indication of reduced circulation to the brain and low blood pressure. We need to know if this patient has previous history of coronary artery disease, previous history of coronary stents, hypertension, diabetes, previous history of heart surgery. Is there any history of bleeding? All these things are very important in managing this patient acutely and in the long term. Does this patient have chronic atrial fibrillation? Is this patient on anticoagulants? All these things are important because it will have a direct bearing on how these patients respond acutely and in the long term. Does the patient have stomach ulcer? Is there a contraindication for antiplatelet agents or anticoagulants? That's why it is very important to know what medications this patient is receiving. So what do we look for in physical examination? I thought physical examination was something that is of the past. You may say, I got an electrocardiogram. We know this is a STEMI. What do you mean physical examination? Are you kidding? Let's get the patient to the CATH lab. I say, hold it. There are a lot of things that we can look for in the physical examination that will allow us to not only treat the electrocardiogram, but more importantly, treat the whole patient. Okay, we need to know, is the patient sweating? Is the patient confused? Does the patient have dyspnea? Does the patient look pale? What is the pulse, rate, rhythm, volume? All these things tell you volumes about the patient's overall cardiovascular function. We need to measure blood pressure in both arms because you could be dealing with a patient with dissection. Does the patient have hypertension? If so, what is the treatment that we need to start? Again, respirations are important because in a patient with labored breathing, a major portion of the cardiac output goes to maintaining the function of the respiratory muscles, and that is an important point that we need to observe because that's going to have a bearing on the cardiovascular demand. Similarly, does the patient have rales or wheezing, which may suggest acute pulmonary congestion or pre-existing chronic lung disease? Heart, more importantly, you need to listen for any murmurs. You need to listen to murmurs. S3 gallop or S4 abdomen, we need to look for any tenderness. That may be a sign of ulcer or something like that. Extremities, are they cold, clammy, cyanotic? And all these findings have a direct bearing on how we treat this patient and what the outcome is going to be with the management of a STEMI patient. Here are some differential diagnoses of STEMI. You may say, what do you mean differential diagnosis? This is not medical grand rounds. We got a STEMI patient here. Let's get to the CATH lab. Hold it. There's an occasional patient or two in your practice career where you are going to come across situations where the diagnosis is different from what you are thinking, namely acute coronary occlusion. You may be dealing with an aortic dissection. That's why recording blood pressure in both arms is extremely important in a patient with an acute STEMI presentation. Pericarditis is another situation which can mimic acute STEMI, and we have seen a handful of patients who have gone for coronary angiography and later on have been found to have normal coronary arteries. Pulmonary embolus can also sometimes present with ischemic changes in the electrocardiograms. We talked about the left bundle branch block already. Okay, here is an example of a patient with acute pericarditis. We also must remember that patients with acute myocardial infarction, but maybe not in the initial stages, but in the later stages, can also develop some degree of pericarditis. If you have acute pericarditis, the electrocardiogram may show ST segment elevation, but you generally see them all throughout the electrocardiogram. Another important point that we need to keep in focus is in an acute myocardial infarction, there is the elevation of the J point, there is straightening of the ST segment and lifting of the T wave with peaked T waves. Whereas in patients with the pericarditis, there is elevation of the J point, but the ST segment has a downward coving presentation, as opposed to a patient with STEMI, where the ST segment is either straight or it is coving upwards. Dissection, I talked about dissection. If the aortic dissection involves the proximal portion of the aorta, it can compromise the circulation in the coronary arteries, and I have seen one or two cases where an acute dissection has presented as an acute myocardial infarction. A pulmonary embolus, as you can see, a filling defect here in a CT of the chest with contrast in the pulmonary artery, and that can also present with acute chest pain. We have diagnosed STEMI. We have excluded all the differential diagnosis. We have started the initial treatment. What is the next step? The next step is obviously, if you have facilities for coronary intervention, the next step is going to be taking the patient to the cardiac catheterization lab. However, if your hospital doesn't have facilities for percutaneous coronary intervention, then we need to think about fibrinolytic agents. If the patient presents with chest pain of less than 12 hours of duration, we can consider the use of fibrinolytic agents, but we have to understand that there is almost 30 to 50% restenosis, which usually occurs in the very early stages of an acute myocardial infarction. There could be some contraindications to use of fibrinolytic agents in certain patients. These patients can also be treated with aspirin and P2Y12 inhibitors. If the patient continues to have ongoing chest pain, or if there are new EKG changes, and if there are contraindications to fibrinolytic therapy, these patients can be transferred to a facility where a rescue PCI can be performed to deal with an acute STEMI patient. There's no question that PCI is far superior to fibrinolytic therapy. As you can see in this study, death, recurrent MI, and recurrent ischemia, all of these are considerably lower in patients treated with PCI as compared to fibrinolytic agents. There are certain contraindications to using fibrinolytic agents at the offset, and these include previous history of intracranial hemorrhage, ischemic stroke in the preceding 6 months, recent major trauma or surgery, recent gastrointestinal bleeding within the past month, aortic dissection. All these things need to be excluded before a patient is considered for fibrinolytic therapy. Okay, now everything is set. You are ready to take the patient to the cardiac catheterization lab. Let's change gears here and look at this picture. Now, the only person who is worried about this STEMI seems to be the cardiologist, the interventional cardiologist. But somehow this whole picture looks like it is staged to me. Look at this. We got a young patient here who is representing a STEMI patient. This could be a medical student, and we have the senior resident asking the medical student, how does it feel to have a STEMI? And the medical student is probably going to say, okay, do you want to take my place? And behind here is a cardiology fellow who is not even pushing the stretcher. Anyway, the patient needs to get to the cath lab as soon as possible. Okay, let's look at some coronary angiograms so that we get an understanding of what happens in the cardiac catheterization lab. In the cardiac catheterization lab, a catheter is inserted either from the groin or from the arm into the coronary arteries, and coronary angiograms are performed. If there is a subtotal occlusion of the coronary artery, that can result in an NSTEMI, which is also treated with placement of coronary stents, as you can see in this diagram. But if there is total occlusion, this is usually resulting in a STEMI, and this is also opened up. First, a guide wire is passed through this region, and a balloon is inflated to compress the plaque, and later on a stent is placed to open up the circulation after an acute STEMI. One important point I want to bring in this particular image is that there is a proximal occlusion of the right coronary artery, and when you see the proximal occlusion of a right coronary artery, you always think about involvement of the right ventricular wall along with the infraseptal region of the left ventricle. Here's a total occlusion of the left anterior descending branch, which involves the anterior wall, the septum, and the left ventricular apex. And after opening up with a stent, there is re-establishment of the circulation in that region. To give you an idea of how a stent is placed, after opening up an occluded artery with a plain balloon, a second balloon with a stent mounted on that is placed in the region of the critical plaque. When the balloon is inflated, the stent is expanded, and when the balloon and the guide wire are removed, the stent is sort of plastered to the arterial wall where the plaque was there before, and it stays there permanent. Now let's talk about the real drama after a STEMI has been treated with percutaneous coronary intervention. We need to look for complications such as arrhythmias, mechanical complications, or ischemic complications, along with some minor complications such as DVT, pericarditis, or even pneumonia. Especially these things are more common in older, sicker patients. Here's an example of what can go wrong in the intensive care unit. These patients can develop acute pulmonary edema or hypovolemia. They can also develop cardiogenic shock or arrhythmias. You can pause this and look at the overall treatment plans for each one of these situations. Let's focus on some mechanical complications following STEMI. The rare complications can include papillary muscle rupture, which can lead to acute mitral regurgitation, pulmonary edema, or a ventricular septal defect. In fact, right ventricular infarction is fairly common in patients with inferior myocardial infarction, and it can happen in almost 20 to 50% of the patients with inferior myocardial infarction. Extremely rarely there could be a free wall rupture of the left ventricle, which is almost uniformly fatal, and cardiogenic shock if there is involvement of a large area of the left ventricle. Cardiac tamponade is also a rare complication. LV thrombus is something that can develop in the later stages. Here's an example of a papillary muscle rupture where one of the leaflets here is detached from the papillary muscle. There is a severe mitral regurgitation, and these patients present with holosystolic murmur. This is usually seen in patients with inferior or infraposterior myocardial infarction. They have a prominent V wave in the pulmonary capillary wedge, which is resulting from severe mitral regurgitation. The mortality is very high, and the only treatment that can really save them is a surgical procedure. Here we have a ventricular septal defect, which is involving the membranous portion of the left ventricular septum. Here's an echocardiogram where we have the longitudinal axis of the heart shown. Here's the septum, here's the posterior wall, and here we have the aorta, and behind that is the left atrium, and here the Doppler shows there is flow from the left ventricle into the right ventricle, and here's a diagrammatic representation of a flow from the left ventricle into the right ventricle. Cardiogenic shock can result if there is involvement of more than 30 to 40% of the myocardium during an acute STEMI. It results in hypotension and tachycardia, 50 to 80% mortality unless it is treated aggressively with the intra-aortic balloon and possible coronary intervention or cardiac surgery. These patients will have a cardiac index of less than 2 liters per minute and a very high wedge pressure. Again, intra-aortic balloon pump may help to support their perfusion until we can decide a more definitive treatment to preserve the left ventricular function. Let's talk about right ventricular STEMI. Right ventricular STEMI occurs, as I said, more commonly with proximal occlusion of the right coronary artery, which also involves the branches supplying the right ventricular wall. A patient with the right ventricular infarction presents with hypotension, clear lung fields, and raised jugular venous pressure. The treatment for these patients, in addition to coronary intervention, is to support their volume with fluids along with the dopamine. We also need to watch for bradycardia or any evidence of heart blocks which can occur with the right coronary occlusion. Here's an example of an acute inferior myocardial infarction with R waves in the anterior leads along with ST depression, which suggests inferior myocardial infarction involving the posterior wall and possibly right ventricular wall also. What about managing these patients in the intensive care unit? Well, the interventional cardiologist has done his job. He has already gone home. The nurse calls the cardiology fellow and he says, call the medical resident. It's 3 o'clock in the morning and you are the resident. What do you tell the nurse? You just tell the nurse to pull out the standard post-PCI orders and check all of them, and you will see the patient in the morning. Wait a minute. What about the intensivist in the intensive care unit? Well, in reality, it is the job of the interventional cardiologist or the fellow who scrubbed with the interventional cardiologist to write post-PCI orders because they are complex. Only the cardiology fellow and the interventional cardiologist know what happened in the cath lab and how this patient needs to be not only treated acutely but also anticipate complications and be prepared for those complications if they occur. Again, we come back to this the medical protocol, which involves aspirin, nitrates in an acute situation for control of pain, beta blockers, heparin, ACE inhibitors, and antiplatelet agents along with high intensity statins. You have to kind of memorize these things. P2Y12 inhibitors before or after the cardiac cath. It all depends. If the patient needs to go for surgery, then giving these agents can significantly increase the risk of bleeding. If you do decide to give, the patient should receive clopidogrel 600 milligrams or ticagrelor or Brilinta 90 milligrams or prasugrel 60 milligrams. In the long term, ticagrelor is contraindicated in patients with heart rate less than 50 beats per minute or if they have a history of intracranial hemorrhage or TIA or stroke. Prasugrel is contraindicated in patients with less than 60 kg body weight and if they are more than 75 years or they have a history of intracranial bleeding or stroke. Beta blockers play an important role in the management of a Stemi patient. It can be given intravenously. The most commonly used medication is metoprolol 5 milligrams every 5 minutes up to 15 milligrams. This can be followed with 25 milligrams of metoprolol twice in the later stages. But we need to watch patients who have signs of heart failure or low cardiac output or shock, or if they have they have second degree or third degree heart block, or if they have severe obstructive pulmonary disease. There are no studies which show the evaluation of oral beta blockers alone in a patient with acute myocardial infarction. Continuing with the medical management, we need to consider ACE inhibitors as an initial drug of treatment in acute myocardial infarction, especially so in patients with reduced left ventricular ejection fraction along with the presence of hypertension and diabetes. We can start them with enalapril 2.5 milligrams twice daily and gradually increase that based on the patient's blood pressure. If the patients have a problem with ACE inhibitors, they can be treated with angiotensin receptor blockers. Aldosterone is used in the later stages if the patient has reduced ejection fraction along with diabetes mellitus as long as their kidney function is normal. And of course, high intensity statins such as atorvastatin or rosuvastatin in high doses are generally recommended for patients with Stemi presentation. The long-term presentation is again continuation of aspirin, beta blockers, ACE inhibitors or ARBs. Then we have P2Y12, it should be, sorry for the typo here, inhibitors for at least 1 month for bare metals and at least for 1 year for drug-eluting stents. Again, we talked about high-intensity statins. And finally, we need to pay attention to smoking cessation, control of blood pressure and blood sugar, and recommend an exercise program and weight control. Smoking cessation is an important factor that we need to take into consideration as much as we focus on controlling blood pressure and blood sugar. It is interesting, we were calculating a pre-test risk assessment of an intermediate coronary syndrome patient, and a 44-year-old patient was put into the database along with his cholesterol levels, and his risk came back as 1.7. But when we went back to check and see if we had entered everything, when we entered smoking as another risk factor, his risk went from 1.7 to 5.7. So that is a clear indication that smoking can take you from low risk to intermediate risk level, and hence smoking cessation must be an important and integral part of management of patients with acute coronary syndromes and also patients with acute myocardial infarction. Prognosis post-MI. The mortality in the first year following myocardial infarction averages 10%. The subsequent mortality is in the range of 5% per year. 80% of the deaths in a patient with acute myocardial infarction result from coronary artery disease as such, and 50% of them are sudden, and they happen in the first 3 months, and 33%, that is 1/3 of the deaths, happen within the first 3 weeks. So it is very important not only to treat these patients acutely with the coronary intervention or fibrinolytic agents and the medical management, but more importantly, they need to be very closely followed in the office to make sure that they are staying on the medical regimen, they are not missing any medications, and their electrocardiograms and the symptoms have remained stable after the initial assessment in the hospital. Well, ladies and gentlemen, this is a brief overview of diagnosis and management of STEMI patients, and I want to thank you so much for your attention, and please do subscribe to our YouTube channel. Thank you again.